Next speaker, Arthur Kavanaugh. Art is Professor of Medicine, UCSD. He's Director of the Center for Innovative Therapy in the Division of Rheumatology. He received his MD degree in St. Louis, his internship and residency at Baylor, fellowship at Baylor, and then he was also a fellow at UT Southwestern. And he's editorial board of a number of journals. He's expert in psoriasis, and he's going to give us a talk on new targets in psoriatic arthritis.
All right. Well, thank you very much, David. Thanks for having me here, having me back here, and congratulations. This is the 30th year that you've done this, which is absolutely amazing to put together a very high-quality meeting, and people vote with their feet, so you see how well received this meeting is. Having had a little bit of experience at this, because for the past 7 years, I've put together a medical meeting, the Rheumatology Winter Clinical Symposium, and even before I did that, I thought, oh, this is really good that David does this, but having put this together, this is unbelievable how he does this every year, because one of the things I can tell you is that the day after this meeting, when you think about CCR 2015, you start from zero. So he has to really create everything from scratch. These meetings take a ton of work to put together to get the speakers and the funding. So really, kudos to you, David, and your wife, Pam, for putting this together. And also, apparently, the ACR has not shot you in all 30 years. I don't know how you've avoided that, because they don't, sometimes they don't cotton to other people doing education. So, but the more we all learn, and I always say we learn more from each other. All of us are smarter than any of us, so it's a real pleasure to be here. And it's very, for me, it's a real pleasure to talk about psoriatic arthritis. Super hot field where those of us who've been around a little while have just seen absolutely tremendous changes in ways that we're now talking about differences in immunopathophysiology, but most important, we're talking about differences that really allow us to do better for our patients. Here are my disclosures, although at the break I'm certainly willing to entertain more. Anybody wants to meet me out in the... If you look at psoriatic arthritis has been tremendous interest. Well, yeah, we can actually prove that. If you look at publications and see a number of publications that speak to psoriatic arthritis, you see that there's some. We've always known about psoriatic arthritis. In the 80s, we would see people with psoriatic arthritis. And what do? Well, we mostly treated them like we did our rheumatoid patients. We'd give them gold injections. We were starting to use methotrexate. We learned about using sulfasalazine from the VA cooperative study and from our European colleagues. But you see there's a tremendous uptick. And of course, that correlates with the first introduction and testing of highly effective biologic therapies, particularly the TNF inhibitors, in patients with psoriatic arthritis. And of course now, as for our younger colleagues, the fellows who have grown up at a time when these are widely available and widely accepted, it may be really even difficult to grasp how revolutionary this was, because now all of a sudden we're talking about the ability to make a dramatic difference in the arthritis of patients with psoriatic arthritis, and then all the other aspects of disease. So exciting in rheumatoid arthritis that we have new therapies, perhaps even more exciting in psoriatic arthritis. One of the tangible benefits that came from the increased interest in research in psoriatic arthritis is it got all of us thinking. It got all of us thinking not just about newer therapies, but also what about the disease itself? And indeed, the ability to do better for patients helped drive the collaboration of rheumatologists and dermatologists into, for example, GRAPPA, the Group for Research and Assessment of Psoriasis and Psoriatic Arthritis. So this group came together and said, well, we have new therapies now. What's the best approach to disease? And that involves looking at the disease. And this is the approach that we had taken, and this is now going back to about 2003, and said, what is this disease, psoriatic arthritis? We've all known about it, but if we're going to do the best for it, we got to take a step back. And one of the things that became clear is that all the different domains of disease, which all of us really assess and take into account as we see patients in our clinic, we need to consider these in ways separately and see what the data was for them. So patients have peripheral arthritis. They can have peripheral arthritis every bit as bad as rheumatoids, but some don't. Some have oligoarticular or asymmetrical arthritis. Of course, skin psoriasis and